right, welcome tonight. You're here in the headquarters of MD Spine Care. Tonight we have an exciting program for you in education. First in a mini series of topics, we're gonna talk to you. We have a panel today of Dr. Gerling, Dr. Warwick, and Dr. Hahn, experts in the field here in San Antonio, providing the latest care and treatment of our patients here in our great community. The topic tonight, we're going to talk about some hot topics. But tonight's topic is stem cells, amniotic cells, as well as regenerative medicine. My background here as a spine surgeon, orthopedic surgeon, and researcher has always been towards health and wellness and regeneration. Now that's the focus of all of us. You're going to hear tonight stories about patients. We're going to have a live demonstration of an injection in the knee from one of our patients. So it's an exciting time. So just a little background of where we are right now with the science of what we're doing. The concept of what we're trying to accomplish with our patients is healing naturally, utilizing the body's own potential to heal. And now we have some science that we can utilize and talk about. Stem cells and amniotic cells are really they're really potent engines that will start our own healing and regenerative process. So when I talk to my patients about this technology, I'm excited about this. It's a growth period. We finally have science behind what we're doing. And when I talk to them about that is that we can take cells, whether they're from your cells or from amniotic fluid, and re-inject them into an injured area. Or an injured area can be anywhere now from tendons and muscles and joints and nerves and discs and other areas that are injured and causing our patients problems. And then with this technology, we aid the body's natural healing and actually even supercharge it. These cells, and not only the cells, but the proteins and RNA and DNA of these cells are potent building blocks. And so what happens when we inject these materials and cells into the body and fluid, it prompts our body's response, and it causes some things to occur. As you know, we want to decrease inflammation. These cells and fluids are very potent anti-inflammatories. So it's like taking a Motrin, but taking a natural Motrin, taking something that's natural in our body and harvesting our natural anti-inflammatory processes by these injections and treatments that we're doing, decreasing inflammation through proteins and our body's response. We also can cause increased what's called angiogenesis, which is increased blood flow. We all know that when someone's injured and has problems, there's inflammation. We want to calm down. We're also trying to decrease the inflammation, at the same time bring our healing cells into the area. So the studies now show that by injecting the amniotic fluid or stem cells into the area, it promotes our body's own growth factors that will then cause our new blood vessels to grow into that injured area. That again brings in, what does it bring in? It brings nutrition, it's oxygen, it brings all these cells, white blood cells to fight infection, red blood cells, all these things that we need to recover from an injury. The other topic that we're going to talk about tonight is really the proliferation of tissue. Stem cells and amniotic cells can cause our body to do something which is amazing. There are some studies now that injections into knees and areas, they can actually regrow your own body's cartilage. So if you've been told, hey, I have a bad knee and a bad elbow, a bad shoulder, and my only option is surgery, well, that's not true anymore. We utilize techniques to avoid surgery and natural healing. And the studies have now shown, not only in Europe, but now in the United States and centers such as ours, that injecting these cells can actually help your body regrow tissue. Again, cartilage. It can regrow. It can help repair tendons. It can regrow a lot of different disease processes as well as injury. So again, I'm excited about this. We have experts in the field, and our first guest tonight will be Dr. Bob Gerling. Bob, can you join us? So welcome, Bob. All right?
Thanks for having me. I appreciate it.
Oh my God! So I'm so excited to have you here. I know that Dr. Gerling is. I'll kind of tell you a little bit about him. He's one of the experts and one of the leading doctors that have to do with your field. Now let's just describe what you do. But also he has an eye towards research, an eye towards healing, and an eye towards regenerative medicine. And I know that when we talked about this, you've kind of taken this thought process in your practice.
Absolutely. So my background is I'm a fellowship trained orthopedic surgeon specializing in hip and knees. In my practice with Sports Medicine Associates of San Antonio, we focus on the entire person, starting at athletics, which is what our group's based on, but then all the way to advanced changes in the hips and knees that require healing. They require maintenance. If not, then those joints become not something that moves you, but something that slows you down. One of my big specialties is replacements, but before we get to the replacement, it's so important to try to preserve the cartilage in the knee because the replacement's never quite the same as the one God gave you. Regenerative medicine, I think, has been revolutionary for what we do because in a field where we focused on just treating the inflammation, which isn't the problem, it's just the side effect of the disease process, we actually have things now that can help stage that process. We can try to slow down the arthritis. We can try to get the cartilage to heal itself. It's important to have as many different tools as you can, and I think some of the newer technologies with the PRP, Amniotic Stem Cells, it's a really important piece of that arsenal that we use to try to push off that process.
I mean, like you and I was skeptical when
Absolutely.
I'm a cell biologist and
Yeah.
I know the science behind this, and it makes sense in the laboratory and dogs and apes and all these studies, rabbits. Sure. But it took me a lot to determine, hey, I'm gonna try this in my patient. Right. So
absolutely.
What was the kind of thought process that you had to make that bridge? Because I've been using it for a while, but it took me a while to come on board.
Well, I think going into the practice, the guys in my practice, have really helped, revolutionize it coming into the community from an orthopedic hip and knee standpoint already. And they took a brunt of the trial and error to see what worked. And as the products were available, Hyaluronic Acid was huge whenever it came onto the market.
Can you tell the audience about that?
Yeah, so it has a million different names: rooster comb gel, gel shot.
Yeah, we should tell patients we're going to take the rooster comb and grind it up and inject it back in joints.
Correct. Yeah, the active component of that is hyaluronic acid, which I always describe it. People say, oh, it's going to lubricate the knee. Well, I mean, it's kind of a sticky jelly, but that goes away pretty quick. It's really a multivitamin for the cartilage. So we're giving it a boost of vitamin, trying to get the cartilage to heal itself. But it's just a vitamin. It's only as good as what your body can do. We're not inducing any kind of healing. We're just hoping by putting this in there that you have a chance to get better healing potential if your body's going to do that. But there's nothing there to actually stimulate that process. And that sets it apart from regenerative medicine.
I agree. Before what we were doing is we were taking away inflammation, whether it was steroids or hyaluronic acid or other modalities. We're just treating the inflammation and the patient gets better. But in my practice, we saw patients come back after the steroid effect or anti-inflammatory went away.
Sure.
And they're saying, hey, my knee's hurting, my shoulder's hurting, my elbow's hurting. And so, this is exciting in the fact that we're actually changing the biology of the patient.
Sure.
So tell me about your first patient that you did.
Sure. So coming in, what we were using originally whenever I started practice was PRP. That was kind of the main treatment option. The PRP has a lot of benefits. It's coming from the host, so we're doing a blood draw, we're spinning it down. We're getting the healthier portions.
What does PRP stand for?
Platelet-rich plasma. So we're taking down the supernatant, we're taking down the area that's got the most healthy cells, and then we're putting that back into the body, hoping to give it enough of those carriers to try to help stimulate. So instead of just using something that's passive, that's treating the inflammation, it still has an anti-inflammatory properties that are naturally anti-inflammatory, but we're actually trying to help that regeneration of the cells.
Do you see that this part of your practice is going to grow, or where do you see this happening as far as your specialty?
I think it's absolutely grown. Part of that is as you have options, people that were stuck in this mentality of, oh, well, I've got early arthritis, meaning certainly don't need a knee replacement, but man, I really wish I could still run. I wish that I could still bike. I want to play with my kids. I want to play with my grandkids, but I'm not ready for a replacement yet. And I think filling that void in between to try to keep people active, keep the cartilage healthy, but then also hopefully we're going to push off that knee replacement. Don't get me wrong, I love operating, but not until somebody absolutely needs it. There's so many options between when the pain starts and when we need to hit the operating room.
Yeah, so the science is starting to get more and more. I know that in sports medicine, we're some of the leaders in the United States at least for injecting materials. PRP, which is platelet-derived plasma, stem cells, as well as now amniotic cells.
Right.
Now in other specialties, I can speak in the spine world. We are starting to see our studies start to come to fruition, and we're getting longer studies. Recently, there was a study that came out where there's a study that shows very promising effects of injecting amniotic fluid into a disc for changing someone's degenerative disc disease.
Okay.
So the studies were what's called a level 1 study,
right,
which means it's the highest level of scrutiny, and so we're excited, and this is exciting times for us. We're in the cusp of this door opening for our patients.
And I think even being skeptical, I think it's healthy to be skeptical, and I don't think that any of us want to pretend that we have all the answers on this yet. It's still very early, and the data is going to be hard to acquire right now because there's so many variables in the market. And whenever we look at studies, you'll see some that show positive, some that don't show the difference. What we aren't seeing is downsides, meaning there's not a lot of risks.
I was going to ask you about side effects.
Yeah,
have you seen any in your side effects?
It's similar to any other injection. You're going to get achiness at the site. Usually that's more related to adding volume. Whenever we add volume to a joint, to a space, to a tissue, it's not going to like that at first. So you have to let that swelling come down, get that initial response. But then usually after that, it's fairly benign, less of a response than they get even with like a steroid injection.
I've seen that too. We've been injecting joints in the spine and other areas, and the response is really much less than steroids. It's really, they're like saying, "Are you done?"
Exactly.
And they're coming back. Our patients are coming back healthful and saying, "Hey, can you inject another part of my body?" Because they're seeing some benefits.
Absolutely. Other things, as the stem cells have come along, which have a little bit different thought process, actually giving active cells, which depending on how you do that can be a little bit more complex. But the amnio is nice because we don't actually have to do a blood draw in clinic.
Exactly. It's like, do I stick an IV in someone and draw blood, or do I stick a needle in some bone marrow and pull it out?
Right.
I mean, those are certainly effective ways of getting these cells. And we're really trying to get the cells, and not only cells, but the proteins of the cells and the RNA and DNA. That's really what we're going after. Mm-hmm. Or can I go to a company that has already processed this safely and offer this type of benefit to patients? And that's why I saw fluid flow is one of the things that really offered that kind of option to my patients.
Absolutely. And I think, again, patients would come in and they wanted to do this. They wanted the regenerative, but most people don't want to get a blood draw and, have an extra stick. I mean, one, don't get me wrong, I don't want to be stuck with the needle any more than anyone else. But having to do multiple things before you get to the same. And then again, it's only as good as your biology. You can't get the same type of potential cells as you can from an amniotic fluid where you're going to have it from someone who's got healthier tissue than you may have.
For a fact, I had a really bad experience thinking about IVs of a blood draw.
Right.
So Dr. Early and I were at a research conference, and part of it is they were going to draw blood and then take it and spin it down, and we would be the beneficiary of getting this injection. The other thing is, I'm a guinea pig too, so there's nothing I'm going to talk about or do that really hasn't been done to me. So I've actually had this stuff injected into me. Mm-hmm. And so I think at one point the nurse was sticking me and sticking me and sticking me and sticking me. Mm-hmm. And I want to remember this. I asked the nurse, like, "Do you start IVs?" And she goes, "Well, no. I'm just part-time right now. I work in the psychiatric ward." Yeah. And at that point I said, "Dr. Gerling, can you please come over and start my IV?"
Anybody else?
Anyone else but this lady, right?
I think, and again, I think we can all kind of relate to those type of issues. You've gone in for a blood draw, and it's supposed to be something simple. And I don't want a patient to come in for something that's supposed to be beneficial, and all they remember is somebody trying to get it, blood access the whole time. They even forgot I did the injection at the
Exactly.
The other downside of PRP is if you try to spin down and you don't get enough fluid, you may not get the same host response. So those are all limitations, I think, and it's still a great technology. We still use it a lot. I think it has a place, and then sometimes we use them in combination. We'll do one, and we'll see if we need to do a PRP because they're adding different nutritional values.
They are, and that's really, now it's exciting. We can pick this technology, or that technology for the best care of our patients.
Right.
And I think that's huge. I mean, the people have that open-mindedness towards the technology and pushing the envelope, and not even pushing the envelope, but aware of what we have to offer. Right. I mean, we're giving better care to the patient, and that's the bottom line.
But at the end of the day, nobody's going to know if these things work if everybody refuses to try them. And I think a lot of my patients, I ask them when they come back, I say, "Look, if we don't get a positive response, please tell me. I do not want to keep doing something that's not working." Right. And too often I'll get patients that come in that are ready for surgery, and they'll say, "Well, I had 5, 6, 7 injections, and they really never worked." I'm like, "What are you doing having 4 more?" At some stage, it's a dialogue. I've got to know if it's working, because if it's not, we got to try something else. But again, you got to have those options too. I can't be a one-trick pony and say, "Look, the only thing we can do is this." That's just not true.
It's not
There's
true.
lots of options.
Right, and that's right. That's who we are, stewards. I mean, we are both surgeons, but we are really stewards of our patients. Right. They entrust us for the health of their bodies, their health. And, I'm honored when someone brings them in their mom or their dad or their neighbor. I mean, that's my job is to take care of the patient, and hopefully, we can help these patients avoid surgery.
And I tell every patient, I'm like, my favorite one is the one a patient referred, because to me that means I did my job right.
Right.
And I take it personally whenever somebody does or doesn't have a good experience, and I think we all do. That's why we did this. That's why we got into it.
So a couple things next. So I'm going to have Dr. Gerling, the experts in the knees. I have a patient, one of my patients actually, someone we work with, and you'll be surprised, someone that you know personally, who we're going to have Dr. Gerling. I'm going to interview a patient and also then have Dr. Gerling go with my staff and show you how really atraumatic and really how easy these injections are. Are you ready?
Absolutely. Be fun.
All right, let's go.
We had some technical difficulties last night with our live viewing, with our audio portion. I'm going to go ahead and at this point describe what we're doing with our injection of our patients. This is one of my patients. I actually work with him in the operating room. He's an operating room technician. He complains of significant knee pain. It's hard for him to do his job because of arthritis in his knee. He has swelling, locking, as well as severe pain within his knee that limits sometimes his ability to kind of do some of the things he'd like to do. We've talked to him about the possibility of decreasing inflammation, regrowing tissue, and regeneration, and he's interested now in proceeding with the injection of the amniotic fluid flow. Dr. Gerling is going to demonstrate the anatomy of the knee as well as placement. He's currently right there palpating the soft spot of the knee that commonly these injections perform. It's just right above the tibia bone and just below the fibula bone and just on the inside of the kneecap. We do this all the time to try to kind of localize the best area, and this is actually the place where this patient is having pain. This is my physician's assistant with the help of Dr. Gerling, identifying really the place where the injection needs to go. And now Reem is starting to visualize and palpate the area with the needle. As you know, there's a very small needle, and as you can see here, it's a very atraumatic injection. There's the needle going in place. She gave the injections, and it's done. That's as easy as it gets. What's going to happen next is that we're consulting the patient at this point to things, the do's and don'ts after this type of injection. And it's really looking for signs of infection or bleeding, which is a very, very rare occurrence with any type of injection. He asked me, could he go back to work tomorrow? And the answer is absolutely. This weekend, I've asked him to kind of take it easy for the weekend duties, but really there's not that many limitations with what he needs to do. And he'll see a decrease of inflammation of his knee with the hyaluronic acid. And then within a week or two, he's going to start hopefully to see the regenerative effects of this injection.
So our next expert in the field is Dr. Warwick. So thank you so much for coming and joining us tonight. I know that, and I'm going to step off for just a second here. One of the things I've known about you for my career, I've been in San Antonio now for, maybe 18, 19 years, that you've been a leader in your field. And so one of the things, I know that you're doing a lot of different things with a lot of different technologies. And when I heard that you had adopted regenerative medicine in your practice, I thought that was amazing. So I know you're on the forefront of pushing the envelope and doing the right thing for patients and offering them this type of treatment. So Dr. Warwick I'll tell you, it's kind of not only locally but nationally known pain management doctor. It does a lot of different things. And tell us a little bit about yourself.
Sure. My name's Dr. Scott Warwick. I am in practice here with Consultants in Pain Medicine. I've been with the group going on 15 years now. I'm double board certified in both anesthesiology and interventional pain management. And that's all I do every day is treat a variety of pain problems, from spine problems to joint issues to headaches. And we're always looking for the latest and greatest technologies and treatments for our patients.
So one of the things that I asked Dr. Gerling earlier about, it took me a while to, my background is immunology, cell biology. It took me a while to adopt this, So, I read the papers and things like that. But what made you take that leap?
Probably the primary factor was we're always looking for things to help our patients. Right. And while kind of our current war chest we think is the best we can do, there's patients that don't respond to our medicines or our other injections, our steroid injections, or our lubricant type injections. So anytime something comes out that gives us an additional option, we are always looking to try those things out.
Who was your first person you tried that, either, and there's really kind of three things we're talking about. One is PRP, the other thing is stem cells, and the other one's fluid flow. So I know that recently you started to fluid flow, which is the amniotic, sterile, powerhouse of proteins and cells.
Right. So the fluid flow, the amnio injections, is the primary treatment that I'm doing for this type of therapy, for the regenerative therapy. Kind of my standard patient, and probably the first patients I worked on, were these 50, 60-year-olds with bad knees. So whether it was the result of wear and tear or trauma or degenerative arthritis, and these people were not responding well to therapy, and they weren't responding well to the other types of injections.
Right.
They either didn't want to have surgery, or were trying to postpone surgery for a few years to try to get them into their 60s before they had their knee replacement. So this was one other tool to try on those patients, and we've done hundreds now, and we've had quite success with it.
That's huge. I think, just think about that. Those hundreds of patients you've done in another person's hands would have said, hey, I'm done, go to a surgeon and have surgery.
Either go have surgery, go have a knee replacement, or take narcotic pain medicines every day and
never the answer.
Not be able to work or drive. So this is another tool to give people pain relief so they can keep functioning and living their lives.
What do you think about this technology in regenerating tissue? I have some thoughts about it. What do you think about that?
Right. I think there's lots of good data and good studies, and the science makes sense that you inject these amniotic cells that with growth factors and strong anti-inflammatory factors, and it helps regenerate tissue.
Yeah, we're previously talking about they have angiogenesis, which is regrowing new blood vessels. We have decreased inflammation, and we have proliferation, which is building new tissue, and I think that's exciting. So if I'm a patient of yours and I come to see you, what would you say are the risks and benefits of the treatment?
Sure. So the risks are your standard risks of any type of injection. And really, from my standpoint, the risk of an amnio injection is no riskier than a steroid injection.
Sure.
Procedurally, it's exactly the same. And that's what I tell my patients. It's like the steroid injection I did on you a couple of months ago, this is going to feel exactly the same. The needle's going in the same spot. It's just a different syringe of medicine. So from a procedural standpoint, it's no more risky, no more dangerous than having a standard steroid shot.
What I think is exciting, we have you of course, Dr. Bob Garling and Dr. Hahn here that's going to be on the panel next. But what's exciting, what I see is that this message of regeneration, self-healing, and really helping the patients grow tissue, heal naturally from injuries. I hate to say though, but you guys are really leading the way here. Many of our colleagues haven't adopted this, and I'm not sure why they haven't, but I have to say kudos to you and the other panel members because they have, and that's why I wanted to hear your perspective on this. So where do you think this is going to go? Where do you think our next step is for healing?
Well, I think that this is a great next step in trying to promote just body's natural healing and regeneration, and really avoiding further injury and further pain and further surgery. So if we can, obviously the surgeons don't like this of not being able to do knee replacements.
We really don't mind. That. I'm going to tell you that. We want happy patients too.
But I mean, that's what I tell my patients is one of my primary goals is for you to avoid having to have surgery. And I think every surgeon would agree with that. If I can do a much less invasive, less costly, less risky injection, and they can either postpone or avoid surgery, I think every surgeon would be in favor of that.
I think you're right. And I think that's, we were talking earlier about us being stewards of our patients and taking care of them as people, just not a patient. Really taking care of them. I think that's what we're supposed to do as doctors, you know. And I'm encouraged with the colleagues here in San Antonio that we are very similar minded, that we do take care of our patients. In your group, though, I mean, there are other doctors adopting this, right? Because they must be seeing the benefits in their patients.
Right. I think I was the first person in my group to do this, and then after doing it for the first dozen or two patients and seeing good results, and the patients enjoyed it, having another option, started talking with my other partners, and most, if not all of them, have adopted these treatments now. It's
almost like that old thing, like, let Mikey try it first and let's see what happens, right? Yeah, I've been in that scenario with other groups too, trying to do new things and innovations. Yeah, let's see. And once they start seeing your benefits, then that they come around to you, right, and they say, hey, look, I see your patients are happy and you're doing this, and you're really changing that needle of care to regeneration, as opposed to, I'm just going to take care of your inflammation.
And the patients are very appreciative. They love having other options. Most people in the public are hearing about stem cells. So when I bring it up to patients, most of them have heard of it.
Right.
So it's just a matter of educating them on what it is, why it's effective, and why it's a good option for them.
Is there a patient that you would say that's not a good candidate?
I think any patient with any type of degenerative wear and tear type injury is. Obviously, a broken bone is not a candidate for stem cells. They need to have surgery. But any type of wear and tear on the cartilage, on the ligaments, on the joint, those patients are good candidates for this.
Have you done any tennis elbows or I understand that people are doing carpal tunnel, trigger fingers.
I've done everything from trigger finger to tennis elbow to shoulders, hips, knees. Injected in the spine, into the facet joints, and then to the sacroiliac joints of the spine. So
I think that in dealing with what I do is spine surgery, care of spine patients. I think that's exciting. The facet joints is a joint of our spine, and it's like any other joint, wears out and becomes painful. And there's a lot of syndromes that occur with that. But the idea of injecting some material, which is now amniotic fluid flow, into that and causing natural healing and natural decreased inflammation. Way better than any surgery I can do.
Right.
Way better.
Right. And then there's two major components. One is it's very strong anti-inflammatory effect. So that's what I tell my patients is we usually give you steroids for this, but this other medicine, one is an anti-inflammatory similar to a steroid, but the more important part of it is the regenerative nature of it.
Right.
That helps kind of regrow and regenerate your joints.
Absolutely. I was recently talking to Dr. Erling earlier on the show. I just reviewed a level 1 study in spine that talked about injecting this material into discs and really positive results of decreasing back pain, increasing function. So again, I'm thinking in my patients, okay, you have a bad disc, you have a bad problem. We could have a needle injected in there with great technique, like using a C-arm like this to see in your body, injecting it strategically where you need it, and having these cells heal. I mean, that's a game changer.
Yeah, it's phenomenal, and we're always looking for new studies, better studies, and specifically into the disc. That's a very new thing. I haven't done that yet. Certainly, I can, with my Xray machine, I can stick a needle in the disc and inject it once I feel that the studies are adequate and good. That's something I will be doing as well.
I'll pass it on to you. Someone passed it to me, and I read it. I was so excited about it, so I'll pass that on to you.
Sure.
So the other issues I want to talk to you about is how do you think the best way that we can educate our patients? Of course, you do it every day with how you talk to patients, how you do things. But I think that the forum like this. What do you think about this? Again, the idea is to get experts to talk about things. What do you think about this forum?
I think this is great. I mean, it's much easier to reach hundreds or thousands of people through this medium rather than one-on-one interactions in the office. And every patient, of course, is different in the office. So there may be some patients that aren't candidates for this, whereas this will go out to people out in the community that don't know what amniotic stem cells are, or they think about their mother or their sister or their neighbor that may be a good candidate for this.
So tell me, I'm gonna play patient now. So tell me about the amniotic fluid. Tell me a little bit about that, can you?
Sure. So the amniotic fluid they get it from placentas. So when women have babies, the placenta is the nutrition for the baby.
Right.
So at the time of birth, they extract the amniotic stem cells from the placenta, and they sterilize it and make sure it's safe, of course. And then it gets shipped to me in a tiny little vial. It's amazing. It just comes to me in a little vial.
This size is like this big. Yeah, it has this like powerhouse. It's like superhero stuff.
Right. And then so the reason it's good for you is with your degenerative knee problem, you have lots of inflammation, you have worn down cartilage, your bone is all worn down. I can inject this medicine in there, and it does two things primarily. One is it's an anti-inflammatory to settle down all the inflammation in your joint, and that's what's going to make it feel better quicker.
Right.
Whereas the regenerative component of it, which in my opinion is the more important part of it, takes time. That's not something that you're not going to grow cartilage overnight. That's a lengthier process for that to happen. But the anti-inflammatory component is going to make you feel better pretty quickly, and then you get the regenerative process over time.
So could I benefit if I'm a patient from more than one injection?
Yes, we do. I've done up to three injections on the same patient in the same spot. I think that's a reasonable amount to do.
That's right, and that's what I've seen in studies is that three injections is about that sweet spot of getting the maximal benefit. So if I'm a patient in the audience here, and we're going to have some questions later from the audience, and we're going to have a panel discussion. How would I get into your office?
Sure. So you can find us online. You can find us on Facebook. We're just Consultants in Pain Medicine, Dr. Scott Warwick. I have several offices around San Antonio.
You're not doing Snapchat, are you?
No. I don't even have that one. Although I should to keep an eye on the kids.
That's right. Keep an eye on my kids, right?
But no, you can find us online. I have offices all over town, and my partners have offices in places that I'm not as well.
Gotcha. I know it's been really easy when we want to get a patient into you. That your staff has been great. They've been really responsive to the patient requests that we've sent you, and they all come back happy because number one is that we are in the people business, and I know that from the doctors we have tonight on our panel, we take care of patients, and that's number one. Treat them with respect, dignity, and look out for the best care for the patient. Yeah. So thank you very much for taking my patients, and so I know that there are many patients out there that can benefit from what you do.
Yeah, thank you.
Okay, so next on we have is Dr. Hahn. So we're going to have a panel discussion next.
Okay, I'll be back.
So again, one of the things that our next guest speaker is going to be Dr. Hahn, and I had Dr. Hahn come on. Hey, welcome,
Doc.
Hey, how are you?
Thank you for having me.
I was talking to an old friend of ours that we go back. I didn't realize we go back a long way. We go back a way long way. And so one of the things, the reason I had you come here is we have some of the experts in the community from Dr. Gurley and Dr. Warwick. But you're part of the other side of this now. I mean, you and I were back early days.
Front lines together,
treating patients, with alternative medicines. But now you're on this other side, and I know when you talked to me about fluid flow and showed me the data and things like that, it just blew me away because my interest is the cells and things like that. So tell me about you and what you're doing now with fluid flow.
So I've become kind of the clinical liaison / national distributor for the product. As you know, going back, and we've talked about, patient care is always my biggest thing. So if it's not helping the patient, I don't look at it. Tons of stuff come my way. I truly thought I was out of healthcare, and then this product showed up, and it hit exactly what my passion is in life: getting the patient well and giving access to people who need it.
Right.
And one of the things that when I left being in practice is I got into the rehab space, and one of my frustrations were, and people who had been there with me saw it, poor people go to prison, rich people go to rehab. Poor people were getting steroids, rich people were getting biologics. So when this product came and Medicare gave us a Q code, it was very exciting for me.
It's exciting. So this is something that we're going to talk about, the access. This stuff is not cheap. And the science behind this and the sterility and the exactness of what this product represents, it's expensive.
Yeah.
So I was excited when you approached me, and I know you approached other doctors about a program. Can you tell me a little bit about the program?
Yeah, so the program is, we have a Medicare Q code for musculoskeletal conditions.
What's a Q code?
Q code is a code that's given when basically Medicare says that this is acceptable based on these intended uses. The documentation studies show that it's appropriate, and we will now start paying for this because we're seeing efficacy and we're also seeing cost effectiveness in maybe other areas where they weren't. So one of the things that occurred was before steroids were the gold standard.
That's all we had.
And so it was cheap, it was effective, they thought. Now, after all these years of data, they're starting to find out, kidney issues, osteoporosis.
Our community here, diabetes, there's a lot of healthy heart disease, there's studies now that talk about it actually can be detrimental to cartilage.
Yeah.
So we're doing the best thing in the world, but we really probably weren't.
Well, it's like looking back at bloodletting and thinking, or not washing our hands before giving, it's the same. We're going to look back at some of these techniques that we've done, and we look back now at the surgeries today versus, 75 years ago. And so, yeah, and one of the things that make it unique is it's not a temporary fix. We're getting the temporary relief from the hyaluronic acid.
Right.
But we also get the growth factors.
And that's decreasing the inflammation.
Correct.
Right.
So there's three things that occur here, and I want to make it clear to the audience too. We don't call these stem cells because these are not live cells.
Sure. Sure.
when we get the placenta and we're doing our testing, we're doing a genetic malformation testing, make sure there's no genetic issues. Then we're doing a disease testing. From there, we're irradiating. By irradiating, we're killing all live cells. So we can't call them stem cells.
No, right.
We call them biologics.
Biologics, right.
But what happens is there's 3 byproducts that are very important. The very first one's hyaluronic acid. We were talking earlier in the interview about Syndisk and some of the synthetics.
Some of the rooster comb stuff.
Yep,
right?
exactly. So that's a synthetic version of it. We're giving a natural version here, but we're also getting the benefits of 2 other products. The next are the proteins, cytokine response, cleaning out debris of degeneration, growth factors come in, cause regeneration to occur.
And it's really kind of exactly just the way you talked about it. Decreasing inflammation, hyaluronic acid, washing out the debris, washing out all the garbage that your body's producing with this injury or this degeneration, washing it out, and then getting our own blood vessels to grow in the oxygen, the nutrients, and the vitamin, and all the mineral, everything we need to make those cells, our natural cells, grow.
Right. Yeah, that's exactly it. And that's what excited me about this, because with my background and, again, my patients and people who know me, I always want to find not just the Band-Aid, but some kind of fix, right? And so steroids are great. They're great for temporary relief. The patient shows up, they need this repetitive cycle, where now we're getting the anti-inflammatory response that we were looking for with steroids, still getting those benefits, which, by the way, the patients feel relief pretty quickly, and it's important for the physicians out there to remind them that it's temporary. We got to wait for the growth factors and other things to occur. But then after that, then we get the next aspect, which is the regeneration. Like you said, the cleaning out of the debris and the growth factors. So they get the best of both worlds. And for the first time ever, the demographic who needs it the most, the 65 and older, who usually are on fixed income, who can't afford these new kinds of products, are able to get access to it.
Can you tell me a little bit more? Yeah, that's really exciting about your company reaching out. So a couple of things I saw when you approached me about this product was, number one, that your company took the forefront and the wherewithal to go to the Medicare and say, what do we need to do to show you it works, it's effective, and it can change people's life. And your company did it and went through Medicare. So for Medicare to give you that stamp, that's huge.
Yes,
I mean, that's huge.
To the point, on the document, on the actual notes, it specifically states in paragraph 2, intended use language, which is very important because right now we're the only ones in the country that have it.
Say that again. I mean, because that's important.
Intended use language.
I can come to you and say, I can make this in my somewhere lab, but what's different?
What's different is intended use language, on-label usage, right? And what that entails is a bunch of money and a bunch of documentation and proof. But once you get it, now we are on-label use. Therefore, there's no risk to the doc, right? So the doc's able to basically give the injection to a patient who maybe couldn't afford a cash pay $3,000 injection.
Right.
That now Medicare is saying, okay, when we do our algorithmic breakdowns and we're seeing cost effectiveness of this treatment versus this treatment, we want to incentivize doctors over here because we're seeing the long-term cost of steroids is not exactly what we thought, way higher than we wanted. We have a lot of egg on our face because we pushed doctors to give narcotics back in the day when we did the pain scale.
Yes.
And we don't want to really pay for surgeries and put patients in the hospital or surgery centers.
Which isn't really the best choice anyway.
Right.
Right. I mean.
So to the point with this product, it will only be reimbursed in the clinic or home setting. They will not reimburse in the ASC, surgery center, or hospital because we're trying to keep the patients away from there. Cost, B, COVID, right? So it's a kind of a double whammy.
Right.
So the idea now is, okay, we're going to actually start looking at cost effectiveness. Let's look at this product. Wow, this has some great research, some efficacy. Let's start incentivizing docs to use this instead of these other alternatives.
Exactly. And so that was where when you came to me and presented me the scientific data, I was impressed with the nature of the studies that were performed, the depth, the quality of studies. And the other thing, you had to get that code, you had to prove to Medicare that it was safe. Number one, is it safe? And number two, does it do what you say it does?
Right.
Right? And that's huge.
And they're not going to just approve it if it doesn't.
No, they're not, right?
We know them better than anyone.
Right. Yeah. Medicare's a whole different program. Yeah. We're talking Medicare, maybe not, but so when you came to me and talked to me that, again, I dove into research, I asked people, I started talking to people, and went back and did some of my own little reading about this, and it was impressive that your company could get through the hoops. I mean, Medicare's a tough bird to kind of work with, and to go through that, I mean, that's a big deal.
Yeah, it is a big deal. And that's one of the reasons why I'm sitting here and I'm back in healthcare, because it excites me, right? We're giving access to people who need it.
Right.
and that is what my whole purpose ever was. And B, it's progressive, and it's not just putting a Band-Aid on. It can have much higher efficacy and effects with it.
You know, what you spoke at was, there are centers around the United States and around the world where if you have enough money, you can go there and get this done. But you had to have enough money before, and that's not fair.
Correct.
And that's really not fair. So like you're saying, this technology was available for the wealthy people that could afford it.
It's been available for 10, 15 years. People have been doing this whole time.
I've been doing it for a long time.
Only the wealthy, and that's not fair.
I've been doing it a long time under research. But right now we can offer it to, like you said, the people that really can benefit the most. You know, the patients that, again, can't afford this stuff.
But who need it.
Who need it.
They have the highest degeneration rate, the highest pain, functionality rate, the highest opiate addiction rate, the highest steroid use rate, highest surgical rate. It excites me. Yeah.
It excites me too. And so, that's one of the impetuses of tonight's discussion with our panel, because I have colleagues here in San Antonio who adopted it. Number one, because it's safe. It's safe. It's reaching out to our population here in San Antonio. They really need it, and we're helping patients. I mean, that's a big deal. And for surgeons to say, we're going to give you a shot that can help you not have surgery, that's a pretty good thing. So
all right, so we have some questions from the viewers.
Oh, you do? Actually,
so
Dr. Gerling, Dr. Warwick, come on back on.
Come on over and do a panel and ask. We're going to do a little Q&A. I do want to apologize to all the viewers on Zoom. We're glad that the Facebook people had a better audio experience. So thank you guys so much for...
We need one more chair, guys.
One more chair?
One more chair. Okay.
So you have some questions for the audience?
Yes, they want to know, do you use an Xray? Look at all these resourceful men over here.
How many doctors does it take to all do it?
Come on here. Okay?
Problem solved.
So, question from the audience.
So the question of the audience, do you use an Xray before injecting the product?
Let's say, so for question, do you?
So there's three ways to do it, I guess. You can use an X-ray machine, you can use an ultrasound machine, or you can do it what we call blind, where you just do it based off the surface anatomy.
Like this?
Yeah.
Okay.
I keep my eyes open. So I do most of them with X-ray. Someone with simple surface anatomy, I'll do that without an X-ray machine.
Dr. Gerling?
So primarily I'm doing knees. The knee anatomy is very straightforward. We know with our techniques we're usually around 94%, which is pretty equivalent of using ultrasound or X-ray, so I usually don't need to.
Right.
But again, I'm not doing the deeper structures like y'all are having to do, getting into the hip joints, spine, things like that. So a lot different risk profile for my patients.
So how would you want your shot done? Would you want someone to use an X-ray or do it?
If it's one of you guys, I trust your...
Or my professor used to do like Christopher Columbus. He didn't know where he was at. He didn't know when he got there, but he showed up somewhere.
So
right?
It depends on practitioners, right? We all know some practitioners, honestly, depending on areas, I would be okay with the dry because I know the doc that I would choose. I would absolutely trust their injection technique and skills. As far as what Medicare requires, none of those are required.
Right.
It is fluoroscopy, ultrasound, all those are absolutely acceptable. It really depends on the clinic, the practitioner, and what they're comfortable with.
Gotcha. Any additional questions from the audience? They're telling us to get together. Another question from the audience we have?
Another question from the audience is, what was in the injection that you injected into the patient?
Well, I can answer that because that was our patient. It was fluid flow, right, which is the amniotic fluid that has then been gone through the process of sterilization, and in it had proteins, RNA, DNA, and growth factors that will allow him to number one, in hyaluronic acid, so decrease inflammation, cause blood flow to come in, and actually heal and regenerate his tissue. That was in it.
And how long did it take to recover after this injection?
What do you think, guys?
So the initial response is usually only a couple of days. It's kind of that we just added fluid to your knee. They're trying to kind of adjust to a new fluid. That's what I've seen. Some patients will say, really, they never get an immediate response, so there's not a recovery involved. I usually recommend folks don't do high-intensity activity for about a week, mainly because I don't want them to turn through the product. The more active you are, the faster you're going to start reabsorbing fluid, so I want as much of it to stay inside of wherever I'm injecting as long as possible.
How about you?
I tell my patients to take it easy for a couple of days. No strenuous activity, no running. Certainly they don't need bed rest. I mean, they can go to the grocery store, they can go to work, just do normal activities, but to try to stay away from strenuous activities for a couple of days.
One of the questions asked of me of one of the patients, and I had some patients ask me today, like, Doc, when am I going to see, when should I expect improvement? And is there going to be a short-term improvement and then a long-term? And those are some of the questions. So how would you answer that?
Yeah, that's what I tell my patients. From the anti-inflammatory component of this product, that makes you feel better pretty quickly. Like within
Do you see that?
days.
Yeah, absolutely.
And then the regenerative process, that takes longer.
Gotcha.
So you get some immediate benefit from the anti-inflammatory, and then the more long-term effect is the regenerative process.
Gotcha. What do you see in your patients?
Same thing. So I usually tell them first few days, anti-inflammatory effect's going to kick in. That's going to last a matter of weeks. And then I usually say, this is probably a 2 to 3 month process in terms of getting the total benefit of regenerative potential.
Mm-hmm.
And at some stage, that's whenever we start talking about somebody need a booster. If they have more advanced disease, more degeneration, do we need to augment? Do we need to add something different? We use the term, and I'm just as guilty. I say stem cell shot because it's patients understand it. That's what's in the marketplace.
But we have to be clear. I mean, and Dr. Hahn's clear. We're talking about with the amniotic fluid, it's irradiated dead cells. So we can't really say live cells.
Right.
But,
and I think
I'm guilty too.
Yeah, and I think
too.
well,
Because that's what people understand, right? Like that's the problem.
And we still call Visco rooster comb, even though it's not derived from rooster comb, and it hasn't been for many, many years.
I know.
I don't think we're being disingenuous. It's just the way that we talk about these products, but the biologic. There's more out there, and that's why I think whenever you look at and we follow these through and we start seeing something that's successful, and we've been using them in our athletes for a long time because it's a lot more common for somebody who's in their 30s, still actively working, trying to play racquetball. They're trying to do things that are really aggressive. They can afford these biologic products.
So would you inject this into Dak when he broke his ankle?
Well, not at the time of the injury. I got a bad one. But afterwards, with the arthritis, that's definitely going to be a concern.
I'm voting for you.
But now I guarantee you he's going to need something down the road. Something's still going to be hurting him.
Awesome. Good answer. Thank you so much for that.
Another question?
So Roy Anthony has a question. He says, I have a neuro stimulator S1L5. Would this be safe for me because my neuro stimulator is not cutting it anymore?
Well,
It depends on what your pain's coming from. So if a lot of people with low back issues may have SI joint problems, absolutely he can.
That's a whole topic. You want to be on that show? We're going to talk about SI joints in our series. Yeah,
invite me back. So it depends on what pain he's trying to treat. So if he has knee problems or hip problems or SI joint problems, by all means he can still have these injections. He could still have these injections into his facet joints of his spine. So the stimulator does not preclude him from having this type of injection.
Oh, no. And what I see some patients who will have a stimulator placed, they'll say, it's not working anymore. Well, sometimes when we investigate, it is working, but something else happened. Right? Something else happened. The joint became inflamed or a disc came out. So, yeah, I think that, that person certainly needs an evaluation. I would actually get a schedule with Dr. Warwick and have him evaluate the patient. And it's an open discussion that he would look at that possibility.
Awesome.
Real quick, one thing that kind of goes into the whole one thing that makes this product unique is that there is really no downtime, right? It's not that invasive. That's the whole point behind it. So in situations like both of these questions, what makes it super unique is the fact that there isn't these downtimes and these issues that we have to deal with other, to the fact that one of the benefits of it being irradiated, we don't have to get our patients off anti-inflammatories because they're not living cells, right? Mm-hmm. So it's pretty easy for the patient in this scenario. Go ahead, sorry.
Awesome. And then I guess everybody kind of wants to know the panel and the man in blue pants. So we're going to just start with you. Just introduce your name for our viewers, please.
Sure. Dr. Scott Warwick with Consultants in Pain Medicine. I do interventional pain management.
Awesome. Of course, we know
Dr. Kuwamura. I'm a spine surgeon here in San Antonio, a researcher, and our practice is called MD Spine Care.
Dr. Hahn, I am acting as clinical liaison for fluid flow in the product and kind of the mediator between the other docs answering questions and helping implement.
Dr. Bob Gerlings, I'm a hip and knee recon specialist, surgical, non-surgical with Sports Medicine Associates of San Antonio.
So one question I have, Dr. Hahn, if we have an audience out here of some physicians that are interested in this product, how is best to contact you to get information that you can start talking to them and their staff?
So a couple of ways. You can respond on the Facebook Live or in the Zoom chat. You can either email me at dominionhcc@gmail.com. Anything from there, if you just leave a note on there, we'll have one of our team reach out to you afterwards to integrate. Super easy to integrate. We make it very turnkey. We also can give you all information in a very simple Google Drive. It'll have all the white papers, the EOBs, the Q code information, the Medicare meeting notes, ICD-10, SOAP notes, all the above. Just drop a line in this chat right here, and we'll get in contact with you guys.
Thank you so much, Dr. Hall. We have another question. Does this work on joints that are fused?
Ooh. Oh, any answer there?
I mean, for hips and knees, we don't have to run into that. Luckily, fusions have been out of fashion for a while, so I don't have to run into that.
The answer is maybe. So here's the thought process. It probably is not going to help with the fused joint. But what happens with the scenario that someone has inflammation around, as we fuse joints, we know fusion's not normal. Mm-hmm. I mean, we're not meant to be fused. But then when something gets fused, we're having to use compensatory mechanisms to move around. And I typically see patients that are fused, we see it in spine all the time, have something else problem. And so the answer, I think, is maybe. If the problem is inflammation around the fused joint or because of the fused joint, I think that's in the sweet spot of this technology.
Yeah, and to your point, you were making it earlier. I tell every patient that comes in with a hip or knee issue that your body's like your car. 100,000 miles. It's not only one thing going on. We treat the one that's the most obvious that we can help the most, but there may be something else that needs help. So I think in that scenario, finding out exactly what the cause of the problem is and trying to narrow that down, which is not always easy, is important.
The other thing, Dr. Early, we have patients in the audience, and so how would someone get to see you in your practice?
So leave a comment. We can reach out. No problem at all. If you also follow my profile, it'll bring you back to our website, which is just SportsMedSA.
Okay, perfect. One of the things that some of the patients have asked me says, am I a good candidate or not? So they raise the question, are there contraindications we asked earlier? And I have my contraindications. Do you have some contraindications for this?
Primarily for mine, is going back to earlier, I was saying I don't want to make somebody a pincushion. We don't want to just keep injecting. So the biggest one for me is going to be the severity of the disease process. There are some patients that I look at and their arthritis is so severe they're starting to erode into the plateau, meaning they're crushing the bone. They've got a major deformity, and if we were to delay surgery, their outcome's going to be worse because of it.
Right.
That's the patient that I wouldn't really push this. Now, if they want to try it, I'm still willing to, but we're going to have a long conversation about what that means. Also, obviously, if you have a history of any kind of allergies to byproducts, things like that.
Other topics would be active infection, cancer.
Sure.
Right. Those are two big things.
Big ones.
Pregnant. If you're pregnant.
And we're going a different route already on, the first two, the cancer infection. We're not even in this spectrum of talks. We're working on major other issues.
Because in my practice, I've had some patients that, I've treated for metastasis spine.
Sure.
And they've known about these products and say, hey, can I get this injection? And I'm like, no.
That's not what this is.
That's not what this is for.
Yeah.
Exactly right. Any other contraindications from the company standpoint?
Malignancy is going to be the big one. One thing I do want to go on that comes up a lot that isn't necessarily connected to this, but ethically, is this aborted fetuses? That's a big question.
That's a great question. I was going to ask you about that.
I wanted to make sure that got in.
Yes, tell me about that.
So this is ethical, guys. I would not, and I'm not even going to get into any philosophy here, but this has to be a live birth C-section. A vaginal birth and a aborted fetus damages a placenta, therefore worthless to us. So anybody out there that's concerned of any ethical, ways that we harvest this is donated or sold by a mother in a hospital to a lab. Then the lab checks it like we talked about, checks it for disease and genetic malformations. Then we irradiate, we vial it up. That's how we get these beautiful little vials for the docs waiting they can just draw from. But again, it is absolutely ethically harvested. Cannot be aborted fetuses, cannot even be a live vaginal birth. It has to be a C-section live birth.
Sure. I think that's important. We really are about ethics, our practices. And that was one of the first questions I asked you, where did this material come from?
Right. And that comes up a lot, and I just want to make sure that there's no
That's huge. I saw a patient today that I thought was a perfect candidate. Shoulder, it's only for a neck problem, but it really turned not to be a neck. It was a shoulder problem. Mm-hmm. So we did an MRI, and not a rotator cuff tear, but inflammation and basically bursitis of the shoulder. Mm-hmm. And the patient goes, I said, I'm going to send you to a shoulder guy, and they're going to inject you. He goes, whoa, I can't do it. My diabetes is really poorly controlled. And I said, whoa, light bulb moment here. let me tell you about this product that you don't have to worry about your diabetes and control things. And so, yeah, we're forwarding to one of our colleagues in town that does shoulders, and they're going to do a flow injection into your shoulder. So just kind of those things of what we're thinking about, how we're in our practice thinking about who are the patients that can really benefit from this.
Sure.
Any other questions from the audience?
No, I think that's going to wrap it up, Dr. K. Thank you so much.
Well, thank you so much. Thank you for the first in the series. I thank everyone for being part of it, taking out your busy practice and things to get here on such short notice, right? Mm-hmm. And we're going to, as you know, in the audience, we're going to have a whole series of topics. I'd ask you to reach out to our staff if there's topics you want to hear about. But the concept of what the program, we're going to ask experts in our field here in our community in San Antonio to talk about the hot topics. SI joints, one of the things. We're going to talk about rotator cuffs. We're going to talk about knee replacements. Are going to be a series. We're going to talk about a bunch of things.
Sure.
And really, the purpose is really helping our patients understand their options. Mm-hmm. So, if there's anything else you guys want to put out there?
Good.
So I think we're good. Thank you everyone for joining us tonight, and we'll keep you in tune to the next conference.
Awesome. Thank you guys.
Thank you.
Thank you.
Thanks, everybody.